In this section, we shall look at HERPES viruses, HERPES virus number 4, 5, 6, 7, and 8. I'm Dr. Abraham from A&E Dermatology Specialist. Let's dive into it. So when you're looking at these viruses, remember what you've said, that the HERPES viruses it's a group of double-stranded DNA viruses, starting from virus number 1, number 2, that is HSV simplex 1 and 2. Then you go to virus number 3, which is the varicella zoster virus. Then you go to number 4, which is Epstein-Barr virus. Then number 5, cytomegalovirus. Then we have human herpes virus 6 and 7. And then you also have human herpes virus number 8. So as you can see in this picture, this is how a virus structure looks like. So this is how you see the DNA at the center, encircled by the protein capsid, and then also the envelope proteins. And then in this picture here, we shall talk about it. This is a lesion caused by a virus, one of these. And I think most of you are familiar with that diagnosis. Maybe you will tell me in the comment section. So when you look at this HERPES virus, as I mentioned earlier, it is a group of large DNA viruses which are double-stranded, and they love causing latent infection, meaning that anytime you get infected with one of these viruses, you are going to stay with that virus for life. So that group of viruses usually divided into subfamilies, and these are 3. We have the alpha group, the beta, and the gamma. So how I love remembering this, I know that alpha is the first one, so it will cover virus 1, 2, up to 3. And then I'll skip number 4, then I'll skip number 4, then 5, 6, 7, and 8. They will be in beta, and then gamma will come back to number 4, and the last one, which is number 8. So these viruses usually establish long life latency in host cells, and they can be reactivated under specific conditions, including stress, immune suppression, and ultraviolet radiation. So going to its virus number 4, or what we call the Epstein-Barr virus. This is one of the viruses in this category of the herpes viridae, and its family is the gamma herpes viridae, and the genus is lymphocyte cryptovirus. So it is also a double-stranded DNA, just like the rest. It was first talked about by a gentleman called Sir Anthony Epstein with his colleague Yvonne Bell. So that's why the name comes from the Epstein and Barr virus. So they named it from these 2 scientists. So Epstein-Barr virus is one of the common infections that everyone gets, and it's also called the kissing disease because usually the transmission occurs primarily through contact with someone's saliva, which usually occur during kissing. But also blood transfusion and organ transplant has also been reported to be one of the ways that you can get this infection. The prevalence, if you have to do serology, 90% of the adults usually have their result turning out to be seropositive, meaning that at one mature time, they got infected with this virus. Very common in adolescents and young adults, and this is the category that usually see manifestation of the disease. Higher incidence has been reported in patients who have malignancy and those in Africa and China. So the clinical presentation in Epstein-Barr virus infection, it can usually cause a lot of conditions, but of the dermatological importance, we have what we call the infectious mononucleosis, presenting as the primary infection of EBV. And this condition is also called glandular fever, or even the kissing disease. Remember, I told you it is called the kissing disease because it is spread through mainly saliva. And in the adolescent period, that's where people start the kissing job. So in symptomatology, usually someone presents with a fever, a sore throat, fatigue, and importantly, lymphadenopathy, which is usually involving the cervical lymph node. And in some few cases, we can see splenomegaly And this same virus has been associated with other blood or hematological malignancies, including the Burkitt's lymphoma, which is also very common in our setting, and the Hodgkin's lymphoma, and then also nasopharyngeal carcinomas and the rest. In HIV-infected patients, whereby HIV is also endemic in our setting, we see this virus causing the oral air leukoplakia, and these patients can also have the chronic active EBV infection. So when they talk about EBV, at least you should remember, one, it is a double-stranded DNA virus. Two, it causes infectious mononucleosis, which is common in adolescents. And when you look at it, and also three, it also has been associated with both malignant and pre-malignant condition. So for you to remember infectious mononucleosis, remember this teenager who goes to the beach, how they get to have fun with maybe their new girlfriend. Then a few days after that, they get a sore throat, a fever, then they get the cervical lymphadenopathy. So that would be the classical presentation of infectious mononucleosis. In the pathophysiology, we know that these viruses, upon infection, if maybe you get into contact with a person who is infected, they'll transfer the virus to you, and it loves infecting your B cells via the CD21 as the receptor, with HLA class 2 as a co-receptor. So they'll attack your B cells. Then within the B cells, the virus will be able to multiply, evade the immune system. You know, when an infection attacks an immune cell, it means that there's nothing that can fight it, right? So those are what we call immune protected sites, including the nervous system and then the immune cells themselves. That's why HIV and all these viruses, they cannot be cured, because they are in part of the in cells that contribute to the immune system. So this virus, after it has infected your B cells, it will express particular proteins that will make it immune, or that will protect it from the effects of the cytotoxic effects of your immunity. The first one is a protein that we call Epstein-Barr nuclear antigen 1, and what we call the latent protein, also 1. So these proteins, they are the ones that contribute, or that they are the ones that switch off the defenses of the B cells. You know, even when B cells are affected, they usually express these antigens of the virus that is infecting them. But now in this case, these proteins will prevent that process, meaning that that cell cannot express that it is infected. So they will hang in there, and every time the cell wants to divide, they will divide with the cell, and then you end up getting reactivation. So you can see in this illustration here, if you get EBV through the mouth after maybe kissing, it will affect your epithelial cells all the way through into the B cells. And then when they reach these B cells, they can now proliferate, because they cannot be touched because of the proteins they express, the EBNA1 and then LNP1. And after that, they'll establish latency for a very long time. And in some cases, they can even spread. You know, when you infect a B cells are usually moving around, right? So they can disseminate and infect different tissues in your body, and then remain latent there, only waiting to be activated. And in some cases, when every time someone gets immune depression or immunity goes down, the cells can actually automatically wake up, and then your virus replicates and then infects more cells, and the cycle continues, and you stay that infection for the rest of your life. So in the laboratory investigation, if you want to investigate to see a person with EBV, so usually we do hematology, where you see a typical lymphocytosis, but usually this is common in acute infections. But we can also do serology, where we test the viral capsid antigen. Then you do the titers for both IgM and then IgE, and then you can see whether it is an acute or past infection, or even a latent infection. You can also do an antibodies against the Epstein-Barr nuclear antigen, and this one usually will appear later on after getting the latent infection. And the monospot test usually detects the heterophil antibodies, and often is positive in infectious mononucleosis. This is not a common test done, but it is also available if you are in better settings. PCR is also one of the modalities we can use, and in this case, you're interested to identify and detect the DNA of the EBV virus. So this can also be used in immune suppressed individuals. So what you usually, and this is how we usually interpret the results, or what you can use depending on the stage of the infection. So within a few days after the symptoms begin, you'll be able to use the ELISA, you can use the IgM, and then also PCR. You can also do bioculture. But later on in the course of disease, after maybe even after recovery, you can still do IgM, IgG antibodies, and then you can do immunohistostaining and then PCR. Also, even viral isolation can be tried, but the effectiveness varies whether the infection is acute or chronic. And then treatment approaches, and then the complications that we expect if someone has EBV. In EBV, usually the treatment, we usually do supportive, and in case the infection is severe with air obstruction, we can give some corticosteroids or especially prednisolone, and then we don't have any specific antiviral treatment. And the beauty is that in this case, your body usually comes up to save you and it will fight off the infection. But when it comes to complication, this is one of the conditions that can actually complicate and affect all your internal body organs. One, we have seen it causing splenic rupture. We have seen it causing even neurological defects like the Guillain-Barré syndrome, that ascending paralysis, even encephalitis. And in long term, we've seen it being associated with Burkitt's lymphoma, Hodgkin's lymphoma, and oral air leukoplakia, especially in HIV patients. And it has more complications. When you go to the cardiac, that is the heart, it can give you myocarditis, pericarditis, even arrhythmias. In the skin, we usually get what we call the aspirin associated rash. So when you have EBV and then, some patients, they do self-medication. So when you treat with with any penicillin, there's a rash that you can usually get because of maybe a drug reaction, and usually it occurs once, but doesn't occur on reuse of the medicine. And then for blood, or what we call hematological, we can get cancers, thrombocytopenia, we can get even aplastic anemia. Especially if someone gets it in utero, you can get aplastic anemia. We can also get Ray's syndrome. In Ray's syndrome, we shall look at it down. And these are other systems that can be affected. Renal, glomerulonephritis, respiratory, air obstruction, even pneumonia. And in the spleen, we can get the splenic rupture, as we have mentioned earlier. So, when we go to the next virus, what we call CMV, or the cytomegalovirus, this virus is also under the family herpes civility, and it also has this linear double-stranded DNA, and it was first described and given the name in the 1950s because when someone got an infection and they examined, they saw that this virus could cause the cells to be very big. Cyto means cell, megale means big. So it caused usually enlargement of cells. So that's why it became cytomegalovirus. And when you look at its transmission, it is also through body fluids. We've seen this already. So saliva, urine, blood, sexual contact can cause transmission of this virus. And it can also be transmitted vertically from mother to child through the placenta. It is part of the torches. As you can see, these minions, this one is trying to give this one saliva, so it can end up infecting them with CMV. So the prevalence is between 40 to 80% of adults. If you do any serology tests, you find that most of us are actually having this virus, or we have ever had this virus in childhood. And this is really high in developing countries. So when you're in a developing country, you need to be very careful because things love us a lot, and you can end up getting a condition because of the geographical location where you are. So when you continue to prevalence, amongst those living with HIV, it's a little bit slightly higher, and even the complication they get when they get this infection is more intense. So the clinical presentation in EBV and associated diseases, we have if someone is has a good immunity and they're healthy, usually this infection is asymptomatic. But when it comes to the immune compromise, they can actually get retinitis, colitis, esophagitis, even pneumonia, encephalitis, all this resulting from HIV. And it is one of the conditions that usually complicate what we call IRIS, the immune reconstitution syndrome in HIV, because people underlook the viral component in immune reconstitution, and they can actually end up with convulsions and brain edema and death because of viral infections that are also reactivated in the immunoconstitution syndrome that affects HIV patients who are being started on medication. And CMV is also very crucial in the perinatal period and in the uterine life because it is transmitted vertically. You can end up infecting the child. So if a child is born with congenital CMV infection, this is one of the leading or the most common cause of congenital viral infections actually. And the symptoms, these neonates will have sensorineural hearing loss. They'll have a smaller head that is microcephaly, and they'll have developmental delays. But at the same time, they can end up developing this, what we call the Brura-Barre baby syndrome. Like in this case, where you have the skin showing you areas that are still forming blood. So this is what we call extramedullary hematopoiesis, where you're forming blood outside of the normal bone marrow that is located in the bones, and then also the liver and the spleen. So in the pathophysiology, this infection of CMV usually loves infecting your epithelial cells. It can infect macrophages and T cells as well, and it will establish latency in the myeloid lineage of cells, including the monocytes. And reactivation can occur in case your immunity is a little bit compromised, leading to systemic infections or serious infections. So as you can see in this animation or in this picture, we are trying to show you that when you get a congenital infection with CMV, you can get both neurological issues, you can get hepatic issues, and then also hematologic issues. This is where you end up with anemia. And then for skin, you can end up with a Brugge-Barre syndrome. So how do we investigate for CMV? Still, we do serology. Remember this is just common for all the viruses. We do a PCR, then we can do histology, and then viral isolation, where you do cultures and you're able to isolate the virus in stem cells. So if you have to do serology, we usually do titers for IgG and IgM. And depending on the result, it can give you an interpretation whether someone has an acute infection or it is a past infection. Maybe a case in point, if you have to look at in this table here, if you do your IgM and it is negative and your IgG is also negative, it means that this individual one may not have had a disinfection in the past or has no infection, so that is okay. But if you do IgM and it is positive, but IgG is negative, you know IgM usually responds to it is the antibody that your body produces in a short time. So this one will show a primary recent infection, but if both of them are positive, then this means that someone has an active infection actually. And if only IgG is positive, that means that this person was infected some long time ago. So when you do histology for CMV, it is very, very diagnostic because it has a characteristic presentation where you see all the inclusion bodies in the infected cells, which I have for you here. So you see now this is a very big cell. You see all this is a cell. That's why we call it the cytomegalovirus, because the cells were very, very huge. And then you see this all eyes. This is one eye. This is the other. So that is the all. I just need to add a little ears here and here, and then you have your all, provided you add on this body. So that's what we mean. This is the all appearance of the virus on histology. So in terms of treatment, the antivirals that can be employed in these infections include the ganciclovir, the ganciclovir, foscarnet, and then cidofovir. So it can also complicate, and complications, we have mentioned them earlier, that this is one of the leading causes of yellow sepsis, especially in the newborns, and it also comes with neurodevelopmental delays and other derangements in other organs, including liver, the eyes, for the retina. We said in immunocompromised, they can get retinitis, which can subsequently end up in blindness. So you go to the next one, which is the human herpes virus number 6. So this one is still in the beta herpesviridae family, so still has a linear double-stranded DNA just like the rest. Though for it was first described in the 1986, initially isolated from patient who had a lymphoproliferative disorder. And this is the structure that we have already looked at. So the transmission is usually also, it is through saliva, this act. And nearly every individual in this world gets infected by age of 2. So it is a very, very common infection. And you know how young babies are there and then their mothers love kissing them. So by the age of 2, someone has already given you the infection. So still, since it also shows latency, reactivation occurs in immune-suppressed patients, including patients who have had a transplant. In the clinical presentation, human herpes virus number 6 is usually associated with a very special dermatological disease, the one we call rosea infantum, also called exanthem subitum, or also called the 6th disease. So this one usually presents with a sudden fever. When the fever subsides in a few days, like after you get a rash, so you get a fever for around 4 days. When the fever subsides, then you get a generalized rash, which disappears after like 3 days. So, and also been associated with febrile seizures, especially in children. You have a fever and seizures, but there's no, the blood work looks normal. So this is one of the possible causes of those febrile seizures. In immunocompromised patients, you can end up with encephalitis, hepatitis, and then bone marrow suppression. So in this illustration here, we see that rosea infantum comes with a high-grade fever, then a rash at the end of the fevers. Then other symptoms can be vomiting. Someone can have a cough. Someone can have conjunctivitis, and runny nose, loss of appetite. These are just constitutional symptoms: diarrhea, a sore throat, swelling of the eyelids, and the rest. So when you're having a child, usually around the ages of 5 and 6, and they're having these high-grade fevers with convulsions, but when you do a CBC, it's normal. Then the fevers are persistent for about 4 to 5 days. Then when the fever subsides, then the child gets a rash. Just know that you've been dealing with rosea infantum or exanthem subitum. So when you go to the pathophysiology, still this virus, the human herpes virus number 6, loves infecting your CD4 cells, which is similar to actually to HIV. And after that, it would establish latency in the monocyte macrophages and even the salivary glands, and this will be for life. If it affects someone who is immune compromised, we should expect severe form of the disease. Still in the laboratory investigation, we can do a PCR, we can do serology, where we do IgG and IgM, and then histology for severe cases, though this is not done on routine. And in terms of treatment, we can use the foscarnet. I think it's one that is common here. I've not seen ganciclovir here, but you can use foscarnet. And then in case the child has this febrile seizures, then you give an anticonvulsant, you give your antibiotic to manage the temperatures, and then you give supportive treatment. Then you go to the human herpes virus number 7. So this is actually similar to the 8, and they actually caused the same line of disease, though this came in a little bit later, where it was described in 1990, I think just a few years before I was born. And still the prevalence is almost universal, like everyone almost gets this infection, and usually it moves together with the human herpes virus number 6. Spread is similar through saliva, and family is the same. In the clinical presentation, usually mostly this 7 is usually asymptomatic, but it has been associated with the pityriasis rosea as well as 6. But however, this is still controversial because in the first reports that reported this isolation, the results were not reproducible. So that means that up to now, the association is there, but with a lot of question marks. In the immune suppressed patients, this can also contribute to encephalitis, pneumonitis, and then organ rejection. So in the pathophysiology, still the infection is similar to human herpes virus number 6. They love CD4 cells, just like HIV, and they will persist in salivary gland, monocytes, and macrophages for life. In the laboratory investigation, for HSV number 7, usually it is only PCR. Whether you have blood or CSF fluid, you can do a PCR, but serology is there, but not commonly used, mostly likely used in research institutions. It has no specific treatment, just like most of the viral infection, we have to do supportive care. And in terms of complication, if you have 2 of them, 7 and 6, you can usually, and you're immunosuppressed, you can have serious complications, including convulsions and even death. So we go to the human herpes virus number 8, also called the Kaposi sarcoma associated herpes virus. So this one still belongs to the gamma family. No, sorry, this one's supposed to be the beta family. It is 8. It is it is the gamma family. Yeah. And then it also has the double-stranded DNA, first described in the 1994, and it has been linked to HIV. So the transmission is usually sexual, which can be through blood transfusion, organ transplant, or even saliva. And it usually loves us, the people in Africa and the sub-Saharan region and the Mediterranean region. And these are usually countries that are still struggling with development. And we have HIV being endemic in our area. So because of HIV, even this virus is enjoying, or it's having its go. So human herpes virus number 8 has been associated with a lot of both hematological malignancies and even solid organ malignancies. An example is Kaposi sarcoma, which is usually a cancer of the endothelial cells seen as a vesicular skin lesion, and typically KS can affect skin, lungs, even the GIT tract. It can also affect the oral mucosa, as you can see in this picture. So someone has this red papillary nodules within the oral cavity, also including even the mouth. And other diseases, we have the primary infusion lymphoma, and then also the Castleman's disease, that mouth-centric Castleman disease. In the pathophysiology, still human herpes virus number 8 loves infecting the B cells and also the endothelial cells, as well as the monocytes. And after infection, it usually has special viral proteins, the ones we call K1 and then VIL6, and these ones contribute to cell proliferation and then the evasion of the immune system. So when the virus invades the B cells and endothelial cells, it will now start producing these viral proteins, and these viral proteins will switch off all the mechanisms that are supposed to recognize that the cell is infected, and the expression to the cytotoxic T cells. So that means that they'll switch off the MHS class 1 processes such that this cell cannot be recognized by the cytotoxic T cells that it is infected. And this is usually a driver for oncogenesis or development of the cancer. And this virus has a few oncogenic proteins that have been reported and have been associated with the progression or development of malignancy in the patients that were diagnosed by KS. For example, it has this protein, the VGPCR, and this one usually promotes the synthesis of the this vesicular endothelial growth factor, and this vesicular endothelial growth factor is very important in forming new blood vessels. And we know that one of the hallmarks of cancer is it being able to form new blood vessels, right? And then we have this viral protein, the BCL12, and this one usually prevents apoptosis. And since it prevents apoptosis, it gives the cell immortality. The cell does not die. Then we have this other protein, the viral IRF protein, and this one usually it activates the CMYC oncogene, and this one is usually against the immunity, or it is antiviral immunity, so it prevents the production of things like the interferons, and interferons are very good when you are fighting viral infections. So this protein blocks that process, and at the end of it all, the cells turn out to be now what? Malignant. So when you're detecting this virus, we can do the viral DNA after taking off a tissue biopsy. But then for histology, you can take off a sample and then release using H&E, and then you'll see these spindle cells with a slit and vesicular, with very many slits, which show vesicular spaces. So as you can see here, this is a blood vessel on H&E surrounded by endothelial cells, and then this is hemostatin, because this is a vascular tumor. So when you bleed, then you have this hemoglobin processed and digested around the cells, giving rise to a chemical we call hemostatin, which will give that dark appearance of the KS lesion. And then you have these are spindle-shaped cells. So these are the malignant cells. They are atypical cells. So in terms of treatment, usually if someone has KS and HIV positive, the first treatment you have to start at, and then in some cases it even responds. If someone, the viral load goes down, then the immune response wakes up, and then in some cases, if the case is early, it can even resolve on its own. But in some cases, it can be diffuse and complex, and then you need to give chemotherapy, and this one requires you to refer the patient to the Cancer Institute. So thank you very much. Once again, I'm Dr. Abraham from E&E, and I encourage you to subscribe, like, and share with your colleagues such that they get to know about the same information. Thank you very much.